All right, it is my pleasure to introduce speakers who will share about the Blue Ribbon panel, expert advisory panel. First, and panelists, you're welcome to come on up if you'd like. Also, while I introduce you, Dr. Natoshia Askelson is a professor in the College of Public Health, Department of Community and Behavioral Health at the University of Iowa. She is the principal investigator for Iowa's Cancer Prevention and Control Research Network, Collaborating Center, and for Iowa's Advancing Immunization Services Research Collaborating Center. Dr. Askelson is a member of the Holden Comprehensive Cancer Center, where she serves as the Associate Director for Community Outreach and Engagement. She is also the Director of the Research and Evaluation Core at the Institute of Public Health Practice, Research, and Policy. Dr. Mark Burkard is the director of the Holden Comprehensive Cancer Center since 2024. He is a physician scientist who investigates genetic changes in cancer and provides medical treatment for people with breast cancer. I think by now we all know Dr. Mary Charlton, who is a professor in the Department of Epidemiology at the University of Iowa College of Public Health, the director of the statewide Iowa Cancer Registry, co-leader of the Cancer Epidemiology and Population Science Program in the Holden Comprehensive Cancer Center, and president of the Iowa Cancer Consortium. She has conducted numerous studies of cancer risk factors, outcomes, and disparities in access and quality of cancer care, particularly among rural populations. And Dr. Robert Kruse joined the Iowa Department of Health and Human Services as the state medical director in October of 2022. Prior to joining Iowa HHS, Dr. Kruse served as the medical director of occupational health at Mercy One in Des Moines. Dr. Kruse is board certified in family medicine and completed his residency training program at Rutgers University. He has a master's of public health with a concentration in environmental and occupational health, and is a fellow of the American Academy of Family Physicians. Would you help me welcome our panelists?
Okay, so I won't freak out.
Yeah, look up there if you're not sure.
Okay. I promise. I try not to freak. Hi, y'all. If you're as cold as I am, feel free to go to the back of the room. Jumping jacks, a little running in place. My fingers are freezing. I cannot feel my nose. Thank you so much for inviting us to talk about what we've been working on for a little over a year now. So this is not the Blue Ribbon panel. These folks are great, but they're not Blue Ribbon great. So we're going to talk to you about the process of putting this Blue Ribbon panel together and what we're learning from them and what's going to happen next. So bear with me while I figure this out here. Okay, I touched that. We've got some goals, of course. I pressed it. I'm waiting. Oh, there we go. Okay. So you all should be pretty familiar with this slide by now. So Iowa is second in incidence rates in the country and one of only 2 states that has a rising incidence. Wherever we go, people are asking us why, right? My uncle in Sutliff, Iowa, my neighbor in Garwin, my primary care provider at UIHC. Everyone wants to know why. We've all been hearing this question from different sectors. Why is this happening to Iowa? What's going on? And we spent a lot of time trying to figure out, okay, so what does this mean? What can we do about this? How can we unravel this problem? We know cancer is complex, right? Mary has pointed that out before. We know it's not one thing, and the cancer you have today, you probably didn't get from something that happened to you yesterday, but maybe something that happened to you decades ago. And so it's a problem, it's a mystery, right, of history and trying to look backwards and what was happening in our state that might have made our cancer incidence rise historically. So hopefully you're also a little bit familiar with this, but when we started thinking about how do we figure out what's contributing to our rising incidence, we needed to figure out which cancers were actually contributing. And so this illustrates that it is prostate, breast, lung, and melanoma. Those are the cancers that if we took them out of Iowa, Iowa's cancer rates would look a lot like the rest of the country. So this gave us some clues that this is where we need to be focusing our work, right? If we're gonna try to figure out what's causing Iowa's high cancer incidence, we gotta figure out what's causing these cancers. What's related to these cancers? Not what's related to other cancers, but these ones. And so this is really where we've spent time focusing our efforts. As we were having these conversations about making these cancers a priority for Holden Cancer Center, focusing our work to really understand these cancers, we did sit around the table and look at each other and say, we're not really the experts in these areas, but we know there are internationally recognized experts that are working on every single one of these cancers. And what if we'd ask them to help us try to figure this out? What if we'd invite them to participate in some kind of interactive process where we could, pull the expertise that they have in their brains out and figure out how it applies to Iowa. So that really brought us to this, the purpose of the Blue Ribbon Panel. So we decided we needed something to advise us, someone that's gonna tell us, I'm an expert in melanoma, this is what I know about the science, this is where I think this is going, these are the things I think you should do. We wanted to know what next steps were. We've got a lot of work in front of us to figure this out. We want to make sure that we're being wise and strategic about what we're looking at. Someone help us figure that out. And then we also wanted to be sure that this was communicated back to Iowans, because Iowans are the ones asking the questions, and they're the ones who have the right to know what's going on. So we put together this panel, this planning committee for the panel. And so you can see folks here on this panel are representing the planning committee, but we looked across the state to look for leaders in cancer and said, who is willing to kind of start this journey with us, help plan this expert advisory panel, and try to figure out what we're gonna do with the results. So we knew we needed expertise right in the 4 cancers that we know are increasing our rates, right? Breast cancer, lung cancer, prostate cancer, and melanoma. So we had to go and find the international experts in those cancers. But we also know we have exposures that we're concerned about in Iowa. So, is it the environment? Is it our challenge with obesity? Is it our challenge with a lack of physical activity? Is it our alcohol use? Is it nutrition? And then we also wanted to be sure we were making the best use we could of the Iowa Cancer Registry. So can we find experts who really have dedicated their entire careers to understand cancer registries? So we started the process of finding these people with brainstorming. Who do we know, right? Who do we see on the lecture circuit? Who have we met at a conference? And then we went to the literature and who is publishing in these areas? Who's got the top science? Who's getting published and doing really interesting stuff? Then we also looked at people's funding records, right? Because if they're getting funding from a federal agency, they're probably doing a lot of work in this area. Are people getting funded? What are they doing? And then we also looked around and who was serving on international boards? Who was being called on by the World Health Organization or by other countries to testify about their expertise? And so we assembled a list of potential panelists, weeded them out, started making asks. Don't tell them, but we had an A list and a B list. And then we also made them go through a pretty extensive disclosure process so that we understood their conflicts of interest. So their first meeting they spent with Dr. Charlton, and Mary describes this process as her second dissertation defense. So she spent a lot of time basically explaining to them, this is everything we know to date about Iowa's cancer. And then they spent a lot of time grilling her, did you do this? Have you looked at this? Did you do this? Have you thought about this? And it was this really great engaged interaction in which Mary was on the hot seat for about 4 hours. It was lovely to watch. Then meeting 2 was when we got to hear from them. So we asked them to really do 2 things. 1, tell us about the state of the science related to your expertise. So what's really known? What do we know? And what are the things that are the gaps or the unknowns or the questions? And then make recommendations to us about what we could do in terms of studies or analyses or data that needed to be collected or current data we had that could be used differently. And so we had kind of these two pieces of information presented to us. They each only had 8 minutes to present. It was like lightning round science. But it allowed them to really focus on the most important pieces of information. We, of course, took all this and have been synthesizing it, and we're still synthesizing it. But we really wanted to report back to you all what we're learning, knowing that this is going to be an ongoing conversation with the experts and with you all and the rest of the state to try to figure out where we go next. So we took what we learned from them and we thought about a few things. We thought about impact. What were they telling us that might have high impact, that might really yield really important, substantial results? And so we rated their recommendations on impact. We also rated their recommendations on feasibility. Some of the things that they recommended us to do were fairly easy, I say, because I don't have to do them. We already have the data. It's just doing a specific kind of analysis. Some of the things they were asking us to do were much more complicated, like creating systems for data collection around environmental exposures. That's not something we can start doing tomorrow. And so we rated things on the feasibility. Then we went back to them and said, we've synthesized what you've told us, and this is what we heard from you. This is how we rated those things on impact and feasibility. And then we had a discussion with them in which they kind of each advocated for their own work and said, you know, I really think the thing you rated as not very impactful is actually very impactful, and let me tell you why. Or the thing you said was not very feasible is really important, and you need to make sure you do it even though it's really hard. And we were able to engage with them in this process. So now we're at the point of integrating that feedback we got from them and trying to turn out some products. And so what you're all gonna see right now is kind of a first draft version of some products and our synthesis of their recommendations. Like I said, this is really first draft. This is not concrete. This is not something where, you know, we're wedded to this right now. We'd love to hear from you all what you think, but we want to give you a sense of what we're hearing from them. So some of the recommendations they made were across all cancers and all the exposures. So across prostate, breast, lung, and melanoma, and across nutrition and alcohol and tobacco and all of those exposures. So one of the things they said is you should really look at things by birth cohort, and that hadn't been something that had been systematically done yet. And if you can imagine, if you think about it really in a simplified way, thinking about it by generation, right? Can would you analyze the people who are boomers together along with the Gen Xers, right, and the Gen Z? So you could kind of see how these people who would have had similar exposures because they would have been of a certain age at a certain time and have certain behaviors that are more similar, can we see changes in the birth cohort? So that was one of the first things that they recommended, and that's already being done now. We've already started to implement that. They also said, we really need you to compare to bordering states and states that have similar exposures, specifically thinking about agriculture or industry, right? So not just Illinois and Nebraska and Minnesota and Wisconsin and Missouri, but like maybe Ohio would be a good place to look. And that work has already begun. I just can't tell whether I pressed hard enough or not. Okay, did I go too far? I went too far. There we go. All right, then they made some recommendations that were just about the cancers, all of the cancers. So they really wanted an analysis looking at trends in stage of diagnosis and grade. And so that work has also already started. We have that data from the cancer registry. That work has started. There's a lot of concerns about screening and the impact screening has on incidence, especially related to something like prostate cancer. And so they really wanted us to do a deep dive in trying to understand screening. And that work has already been started. And then they were interested in what role Medicaid expansion or the Iowa Health and Wellness Plan might have on screening and incidence rate. And that work has already been started. There, of course, were some specific recommendations they had around some exposures or risk factors like smoking and tobacco. So they really wanted us to look at trends related to smoking and related to tobacco cancers. So if we're seeing an increase in lung cancer, and if it's driven by tobacco or smoking, then we should be seeing an increase in other cancers that are related to tobacco and smoking. So they wanted us to look at those. And they also wanted to know why Iowa's smoking behavior might be looking different than the rest of the country. So some of you may have heard there's been some recent analysis that predicts Iowa's smoking rates to be some of the highest in the country in about 10 years. And why would that be? What is it about Iowa that makes us different? Specifically, they were wondering about taxes and policies, but also wondering about this thing that they called the middle of the country effect. As a native Iowan, I took a little bit of I'm not sure I like that. But this idea that, right, behaviors, we see trends, see things start on the coasts, and then they slowly move inward. So because we're in the middle, we adopt behavior change later. And so maybe we're just really slow in addressing smoking. I'll let that one go. Of course, there were concerns about the environment. So they said you really need a better pesticide reporting system. This needs to change. They said you've got to design really high-quality epidemiological studies that help us better understand the risk factors that people are actually exposed to and what happens to them. And then you need to do a better job of conducting environmental monitoring. As you can imagine, these are things that are not things we can do today. These are things we all have to work on. There were a number of recommendations related to nutrition, so specifically looking at some of those things where the evidence is already really clear, like arsenic, if you think about a water, right? Like alcohol. Investigating that relationship between obesity and cancer. We are challenged with obesity in our state. What does that really mean for our cancer rates? How can we track those things together? The role of food deserts in our state and what that means in terms of access to nutrition and the implications that could have for cancer. Conducting water testing, specifically looking at things like H. pylori and arsenic and other metals. And then they suggested that we really do this very comprehensive, deep dive look at people's food intake. So really getting people to record everything, do body composition, blood work, all of that, so we could really much better understand what was going on with people in terms of what they were intaking and what implications that might have. Again, something else that we can't do that today, right? That's something that we can plan for. It's a much larger study. And of course, they made some recommendations that were very specific to cancers. Some of the things, like for breast, they said you really need to think about age at first birth for a woman's first child, or number of children they have. And you also need to start looking at women by pre and post menopause. And so that work has already started. So we're already doing those analyses. Considering people's socioeconomic factors and what access they might have to things. For melanoma, they were really interested in much more of a risk stratified study where we would really be looking at a bunch of overlapping risks that could be causing melanoma. And then testing of melanoma to look at what are we seeing in terms of this melanoma? How is it related to the other melanomas we are seeing? For prostate and melanoma, I touched on this before, screening behaviors. That was something that they really drove home with sometimes your incidence is related to the screening and the screening behaviors of your providers and your population, and we need to figure that out if that's the case. For melanoma and lung, they were you already have really good candidates of things that are causing those things. Focus there because those things are for sure connected. For lung cancer, they were also thinking about housing stock and how housing stock has changed in Iowa and what does that mean for radon? And really, what is our penetration for radon testing and mitigation? And then, of course, for smoking, really looking at those other smoking-related cancers and being able to understand whether things are kind of moving together and all these smoking-related cancers are moving together or whether lung cancer is somehow behaving differently. So I just threw a lot at you, and there's no reason for you to remember any of this. Like I said, our next steps really are going to be synthesizing this, going back again to the expert panel and saying, hey, we've kind of condensed things, collapsed things. Is this still in line with what you're telling us? We're going to go around the state and seek feedback from folks, wanting to hear, what people see, whether this resonates with them and their experiences, whether there's other things that we should be focusing on. And we'll be putting out documents, some kind of, one-pager that's kind of an overview for the very baseline stuff, something that's a little shorter summary, and then a massive report that, those of you who want to dive into that are welcome to dive into that. The Cancer Center has already started to take some action, and they've integrated this work into their strategic plan. It's going to be heavily integrated into our Cancer Center renewal proposal that we're putting together now, and is part of our internal seed grant mechanism and our community grants. So at this point in time, I'm going to stop because I was just supposed to provide the overview. And now's the opportunity for you all to ask questions of the panel that planned the expert panel, and how we're going to move forward from that. So I think there are folks going to go around the room as before and play Phil Donahue. But while they're doing that, I'm going to start the panel out with a low, what's it called when you lob a softball? Yeah. So what was the most surprising thing you learned from the panel? Mark, do you want to start?
Sure. I think you said it, and in a sense it's obvious, but it's the concept of latency. The cancer that you see today is the product of risks that were undertaken decades ago. And so even if today we could, wave a wand and take away all risk factors starting today, we would not see those rates change maybe until 10 years, 20 years down the road. So we're seeing the effects of what the exposures were in the 1990s and 2000s largely today. That just struck me what a challenge this is, and as we communicate how we should proceed as a state and communities across the state, that it's a long-term undertaking to turn this around.
Yeah, I think about this night and day as a part of my job, so I don't know that there was anything that they said that was surprised me as much as I was 100% certain that these people who were people who I've looked up to for a long time, first of all, I was surprised they said yes. I think everybody should feel very heartened that these people who are so busy and so well-funded and so, world-renowned in what they do, felt compelled to help us in Iowa. So that was shocking to me. And I was sure then, when I did my presentation, that they were going to say, duh, it's that, did you do this, or haven't you done this, or something? And they had a lot of amazing ideas, but what really sort of affirmed, this is really complicated. There is no easy answer, even for the people who are very deep experts in some of this. There was no smoking gun. They didn't see it. They had a lot of great ideas. So again, I think it's something that we're all going to have to work together on a lot of this, especially the data monitoring. We only have so much data to work with that we can use to try and figure out what's going on, and we're missing a lot of really important data that it would take to be able to quantify risks better. So.
Yeah, I don't think it was one specific thing. Really, I would just say, for that day, for the first session, I think it was like a 6-hour meeting of some sort, and I said, I'm really not looking forward to this long day. But when we started meeting with these experts in their field and really listening and hearing what they're saying, just when you think you know cancer, there are just some unique aspects that they bring to the table for us to consider. And I think really because of that approach and having kind of that interdisciplinary group all put together at one, Really, it made the day very efficient, but also just hearing kind of very unique parts of kind of the problem as a construct for us to think about solutions. And so I just remark upon that relevance of that day and just thinking through that. And I know we had more sessions after that, and I think even more folks that heard about the day that weren't going to participate actually heard how well it was, heard how their colleagues were participating. We had some folks, I think, in the nutrition and physical activity sector of work actually come and join in because of how profound they thought that day went. So I think just having, again, those different disciplines at the table for us to have the conversation was just eye-opening to hear their different aspects.
And that my attention span could stay engaged for 6 straight hours was shocking to me, but it was the most interesting, like most amazing meeting I've ever been part of.
Yeah, Dr. Kruse is right. There were some folks we approached who were experts who, I mean, some people never returned our email, right? But some people just turned us down, no. And then their colleagues participated and they found out how cool it was, and then they were like, can I change my answer to yes?
Dick Deming, thank you for giving us these highlights, because I've been kind of wondering what's happened to the Blue Ribbon panel. And you're right, not a lot of amazing stuff, but a lot of hard work that has to be done. My question on the environment, you outlined their recommendations, and a lot of it was about more monitoring. We're in a point in Iowa where we are defunding monitoring of environmental chemicals. And the recommendation is to do better pesticide reporting. How do you plan to use, the power of persuasion and the power of this recommendation to perhaps change the process by which we are doing monitoring of chemicals in Iowa? How do you foresee the Blue Panel helping to accomplish some of those recommendations of the Blue Panel?
They're all looking at me. Coming from the state side, certainly, we need to understand the data, and we need to understand kind of where we have gaps in our data to help understand kind of really what the picture is and really kind of what that causal link looks like. I think, that's where I would, number one, start. I think the other part is we should use this as a stepping stone to kind of drive some of these conversations and make sure that we're talking with those in the private sector around the work they're doing and what may be contributing to some of the water quality issues or challenges that we might be seeing. But again, I think we really need to be thinking through this as using this data to tailor kind of our messaging and have those conversations and use that to open up our conversations about what the challenges we're seeing and collectively address those together as a solution.
I mean, I would echo again what I said before. I think Monica's work in Arizona is a roadmap for us, right? We have people in all 99 counties who are excited about this and can be citizen scientists, and we can collect those data ourselves.
Good afternoon. I'm Janice Weiner, state senator here in Iowa. The legislature is a body that may have a role in all of this. Kudos to you all for putting together the Blue Ribbon panel. Clearly, it's a real cancer is an all Iowa issue, and it's also incredibly complex. I'm willing to bet there are a few pieces of low-hanging fruit, though, things that the legislature could do that would have an impact, whether it's on radon, on water monitoring, on cigarette taxes. So, not to put you on the spot, but I'm putting you on the spot, and you're always welcome to come back to us later. What are some easy things that the legislature could do that would improve the situation while you continue to work on the complex stuff?
Raise the tobacco tax by at least $1 is the single most effective public health prevention at all, not just cancer, across the board. And I know that's not easy to do. But the science could not be more clear. And Hans, we will come up with an argument, as the speaker this morning said, about how crossing the border will not cause this giant loss of revenue and everybody will drive over there every couple of days and come back with lots of cigarettes. So we will find a way to make the argument counter to that, to say And also to address the study that's projecting that we will have the highest smoking prevalence in the country by 2035, and we're not even in the tobacco belt. I do these 99 counties presentations all the time with Amanda and some of my colleagues, and we see lots of counties in Iowa where the lung cancer rates are increasing. That is unheard of in the rest of the country, that lung cancer rates are increasing anywhere. We have many counties in Iowa where they are increasing. We have to do something about the smoking rate here. We are getting dangerously close to having the same smoking rate as Kentucky, who has the #1 cancer incidence rate in the country. So that is hands down the most important thing that can be done right now.
Radon, tanning beds.
Yeah.
Yeah, I'll hit on that. So I agree with the tobacco focus there as a leading risk factor. I think certainly I applaud the legislature this past to push out about $20,000 in radon test kits. Was significant. Just to share kind of how fast that went, that was introduced back in August of this year, and within about a month, those funds and kits had run out. And so clearly there's a need there. I think, hopefully everyone knows every 2 years we should be checking our house for radon, our homes or dwellings for radon. Most people just think about that really when they're buying or selling a house. And so just thinking about opportunities about communication there. I will say, testing is one thing. The next step is really around mitigation. So for radon, if you have an elevated level, the next step is how am I going to mitigate my system or my house to improve on that? And so I think one thing is to really have the action to test, and then it's kind of like test and treat. We need to figure out that treatment part and mitigate that. So there's opportunities to think about how we can fund mitigation and radon in that space as well.
And also subsidies for construction people when they're building houses to build the houses with the pipe, with the infrastructure to mitigate right built into the home. We know that the entire state sits on the slab of limestone that is emitting radon and will continue to do so. So we should build our houses accordingly so that people then don't have to turn around and figure out how to mitigate that. And I think you mentioned tanning beds also. I know I talked about that this morning. Again, we don't let 18-year-olds smoke, and we don't let them buy cigarettes at least, and we don't let them buy alcohol. Why do we let them buy unlimited tanning sessions to cook themselves to their heart's content at any age without any parental consent or permission or nothing? There's many states who just absolutely outright ban tanning among minors. Their prefrontal cortex is not fully formed. They cannot see the consequences of their actions in the future. I have a hairdresser who just had her 5th melanoma removed. She will tell anybody who will listen. She went to tanning beds all throughout high school, and she wishes she would have understood. Somebody would have not let her go, and she would not have to go in for melanoma screenings every 6 months to see how many moles they're going to remove, and to be, so afraid of the one they miss. That could kill her. So it's a terrible thing. It's a terrible thing we let our kids do. I know that the counter argument to that is they can just go out in the sun. Well, they can, but they would have to spend their whole day out there cooking themselves as opposed to 15 minutes, which will give them enough UV radiation to increase their cancer risk exponentially, especially if they're doing it at a young age. So I think being one of the only states that has 0 restrictions whatsoever on our minors using tanning beds is sort of an embarrassment to the state that has such a high cancer incidence rate, and I would like to see us do something about that.
All right, over here, Elizabeth Lefferts. Thank you for all this work. I'm excited to see what happens. As a trained exercise physiologist and physical activity epidemiologist, I have a question related to physical activity. Love seeing all the nutrition as a lifestyle behavior, and physical activity obviously can impact obesity. Our built environment as a very rural state is not great. Is there any part of this that has to do with physical activity tracking in your future work? I know this might be cliff notes of what you have planned, so I'm just curious if that's playing a role.
Yeah, we did have an expert in physical activity from NIH. Those recommendations did not kind of rise to the top in terms of being both impactful and feasible. They presented us with a lot more recommendations than what we're showing here. They are in there, but just in terms of how impactful they would be and how feasible, don't have that. The folks that we were invited were really people who understood the causes of cancer, not necessarily understood the interventions that it would take to change someone's cancer risk. So we've talked about, is there a part 2 to this expert panel that would be folks who are much more about the intervention side as well? So that my guess is what would show up more there as well. I don't know, any.
I'll just plug, outside of cancer, I mean, certainly at the public health department, we're watching that closely for obviously obesity-related diseases, and certainly look at that as a preventable space for, especially in the childhood and adolescent space there. But I agree with Natoshia. We didn't necessarily rise to the top as kind of the most feasible kind of space. Doesn't mean that we're not going to think about and addressing that in other areas, but again, when we had a finite kind of time and effort to put around this, and just wasn't the major priority at this point. But I would say at the state, we certainly have an entire bureau. I'm looking over at the table over there of our focus on how we ensure kind of the built environment is around spaces where we encourage that type of exercise and make that the healthiest choice.
And we do know from the behavioral risk factor surveillance system that we have over a quarter of Iowans report 0 physical activity outside of their jobs. None. Not gardening, not walking, nothing. That's a quarter of our population, with only a quarter of our population actually meeting physical activity guidelines, with everybody else in the middle. So it's a huge opportunity for improvement for our state.
So I could add that the University of Iowa, through the public-private partnership funds, is investing in an exercise physiology laboratory headed by Dr. Jess Gorslitz. And that will focus mostly on survivors and previvors, if you will, because there are already 172,000 of them. But some of the things we learn may apply to prevention as we're preventing secondary cancers.
We have an online question. Were any of the recommendations specific to looking at pediatric populations with cancer?
No, I mean, we only asked for experts from melanoma, lung, breast, and prostate, because those are the cancers that are driving our incidence. And then we were looking at just the exposures that were related to those.
I have a couple of questions or comments, but first I want to acknowledge Dr. Charlton for all your efforts. You really have been the mouthpiece for all that, and with the data registry, and I think a lot of expectations were placed on your shoulders, not only give us the information, but solve the problem right now. And as a surgeon, I feel that way too. I want to fix it right now. So my questions are several. Number one, is this a Holden Comprehensive Cancer project? Is this a state of Iowa project? And how is it funded? Number one. Number two is there an open-ended time frame, or when will we have some specific details going forward? Those are my first two questions.
They're looking at me again. The funding actually was Senate File 647, I believe it was, to appropriate about $1 million to the University of Iowa in their budget to work directly with the Iowa Department of Health and Human Services on this Cancer Drivers Project. And it's been a great partnership to work together on collaboratively and thinking about kind of how these strategies will think about kind of how we tailor our interventions, to help reduce cancer in that space. I think, as far as your other question about kind of what are the deliverables around that, I think it will be a preliminary report that we can expect coming up here in December. Again, this work is moving very fast. I think that'll be very preliminary, just given the amount of work and analysis to have there. But then we'll also have kind of a more formal report at the end coming up in June, I believe. Yeah. So we'll look forward to that. Again, the idea is to take those reports and look at that from the state level to really kind of drive and think about what interventions are going to move the needle to help reduce, kind of the cancer incidence we're seeing here in the state.
And the other part of it gets a little bit political, but I'm glad we have some elected officials here, because as I understand it, there were at least 10 or 11 bills at the state legislature this year related to cancer and incidence, none of which were passed. Okay, so I don't want to call out our representatives, but let's get to work, huh?
I think Hans is saying one, maybe one?
One?
Radon.
$20,000 for radon. Why not just make it mandatory? Different topic. The second one is just like the causes and the problems are multifactorial, I think the solution will be too. So I think we should have a blue ribbon advocacy legislative lobbying effort pressed forward to make sure the state and our elected representatives follow through on these recommendations. We can do all the research and have all the ideas in the world, but we got to push things through. And our citizens are aware of this now. We've done a great job of making it aware, but we need action. Thank you.
I think that's really, really wise. I will also just be really clear that none of us on this stage can have any role in that, right? This is now, we are doing the research, right? But we now have to hand it over to others because of our positions and where we're located in state government. It is now up to others to kind of move things forward.
Yeah, I would say, I mean, we're not going to do this alone, and that's part of this convening group is bring us all together so we can share information, be aligned about kind of what we can do and address and be coordinated around that. So I think having a much more of a presence and kind of really a focus for us to be coordinated in our approach to help mitigate this. That's why we're all here today.
Yeah, and happy to always help with the data and the messaging and the responses to the people arguing against moving forward. I think that's where we can be really helpful.
Mm-hmm.
Hi, my name is Scott Cause. My wife Brooke's here with me. Our daughter had cancer and was treated at the University of Iowa. So I had the question that came in about pediatric cancer research. We've been advocating for state-funded childhood. I call it childhood now because pediatrics too big of a word for me. So childhood cancer research, we've been advocating for the last 3 years. Hans knows me well, Janice, Timmy, they all know me. I'm a big pain in their butt. But why do you think 4% of all the research funds go to children? And why do you think, is there a fear of figuring out the cures in children? Why do you think they get so marginalized when it comes to research dollars and they just seem to be left behind? Dr. Dickens was sitting here with us a little bit ago talking about it, and it's an interesting discussion. When you think about research, it takes 10 to 15 years to get an answer from a clinical trial and determine if the drugs are going to help or make a difference. Devin will be 3 in November, so she'll be, 15 years from now, she'll hopefully graduate high school. So why is it that children always seem to be marginalized in this situation?
I can do my best to give one answer coming from a cancer researcher perspective. Is if you look at the history of cancer research 50 years ago, a lot of the progress was made first in pediatric cancer. And that was catalyzed a lot at the National Cancer Institute by a government institute that could bring patients from all over the country and serve their needs and develop drugs. The National Cancer Institute Cancer Centers program was designed to replicate that around the country. But if you look, what's happened is the amount of funds for clinical research has kind of been drained and it's been pushed to industry. And when you have industry partners funding, they look at what's the market. And so a lot of the efforts have been, pushed to the adult side where there are many more patients. So I think if we can catalyze that, move back towards funding from the National Cancer Institute, federal funding, and focus funding on the rare cancers, and there is some talk about this at the National Institutes of Health now, to work on the rare diseases, then we can make more progress. But that's my sense.
I'm going to run through 3 online questions so our online folks don't get left out. The first one is about water quality and pesticide runoff. As an agricultural state, that could be a concerning factor influencing rates. Is what we are allowing as acceptable levels really safe? Might not be the crew for that.
So I can say a couple things. I'm not an expert in this area, but what I can say is if you look at the water quality is important for for all aspects of health, not just cancer. And so I think it is important that we monitor and maintain water quality. The other thing I would say, and Mary shared this with me and others early on, if you look at the distribution of the 4 cancers across Iowa, they're very different. You know, the prostate cancer's in the Northwest, that's where the rates are high and rising. Breast cancer is in the urban areas, melanoma is in the north, and lung cancer is sort of dotted around in the south. And so, again, I think that reinforces the idea that there's not one thing. If there was a water quality primary cause, we would see diseases focused on arsenic or other water-related causes in the areas where there was high levels of those. So I think it could be part of the problem, but it's clearly not the whole thing.
I think the other complicating factor of studying that is how many people in here have drank from the same water source their entire lives? Maybe a couple? There's always a couple, but we don't have a record of all the different water sources you have drank from. You know, we don't know the water quality now. The water quality issues are real, and they need to be addressed for a million reasons that don't even include cancer. So obviously that needs to be addressed, but what's in the water now didn't cause our rates to be high now. And not everybody drank from water in Iowa over their entire course of their lives, and water quality is different. You know, some people are in well water, some people are different. It's just very complicated to be able to quantify the impact of something like that on a very complex disease like cancer.
Thank you. Any other thoughts before next question?
We just want water in our water. How about that?
Yeah, that'd be nice. Speaking of what people drink, were there any findings about binge drinking or any related recommendations in the panel?
I think, you know, we've looked at our burst data, you know, around this and some other data points. You know, certainly we know alcohol, you know, goes into acetaldehyde, which is a direct cellular toxin. You know, it's if we look at our rates of binge alcohol use here in the state of Iowa, significantly disproportional to several states across the U.S. Again, is it the leading cause of kind of where we're seeing kind of the rates that we have? Hard to say. I think we're trying to understand that. I think but it is one kind of modifiable risk factor that can be addressed, whether that's through policy or individual modifiable risk factors as well.
I think the problem we have with this too is related to binge drinking, right? We know that there's no safe level of alcohol in cancer. Like any amount of alcohol raises your risk for cancer, but we really only have good measures of binge drinking at the population level. We're not monitoring drinking in other ways. And so, you know, the binge drinking, or what we might consider more problem drinking, right, is our only kind of mark for that. But we know that, you know, no level of drinking, my Friday night, you know, red wine glass is not safe. So I think we struggle with that.
Okay, one more. Will the report you mentioned include policy recommendations?
They are making recommendations about the research that we need to do to understand why our cancer rates are high and rising. So they were not experts in policy, they were not experts in intervention. This is really only to understand what's causing this.
Thank you. There's 65 people online right now, and the chat has been very engaged. So.
Do you have a number that you'd anticipate that you would need for funding in order to do this implementation once you have all that research? And is that going to come from the state or the federal level, or how do you anticipate getting all that funding?
I'll just make a general answer. There's almost an infinite amount of research and things that one could do. One of the purposes of this panel was to focus our efforts on what's most impactful. As you've heard today, we think there's some policy changes that could be impactful now that we don't need research. So that costs nothing. With the $1 million from the state, we can start to invest in a few other areas of focus recommended by the panel that we can get some more information and answer some questions from the community. 1 million sounds like a lot to me because, I go grocery shopping and I pay a lot less for my groceries. But when you divvy it between many researchers and you expect to start on day one and have an answer exactly a year later, it's really hard to do that. So I'm sure there will be additional questions and things that we'd like to follow up on. But we're trying to, the goal is to deploy that most impactfully.
Rachel Schramm, Iowa Cancer Consortium. Last night's session at the Iowa Oncology Society focused on AI use in oncology, and I'm just curious with this project, have you guys ever thought about using AI, or is that in the Lexis possibilities?
Yeah, I wouldn't say AI, but the biostatisticians that are working on this project are using machine learning types of things, which is analogous, I guess, and using lots of data points to try and look for relationships that we might not otherwise identify on our own. So I would say that's probably the most applicable use of it.
Yeah, I don't know that it's specifically called out necessarily in our blue panel report or what our conversations have been. Certainly, we recognize, we have a challenging space for workforce, for recruitment, for retention in a lot of rural communities. I think that can trickle down to, I was not at that session, but I'm sure there was discussions about use of AI or machine learning for analysis of MRI imaging. I can predict and potentially see kind of in the future that an AI platform will be kind of a standard of care of having that alongside you. It's not very going to replace providers or the workforce, but it's going to be a tool that will be able to be used going forward. So I think for the analysis, for pathologists, for radiologists, for that image analysis to happen, we're seeing large sets of data, complex data sets, and integrating them together to make kind of use of trends and information. That type of data is where kind of this machine learning and AI can be used most effectively. And we'll see certainly more opportunities of that going forward. It's something maybe as we kind of approach our policy coming out of this report to think about just where AI can be integrated more fully.
I have a question. You have a very informed, diverse, experienced, wise audience here and within the Iowa Cancer Consortium network. So when thinking about public health professionals, cancer survivors, advocates, healthcare providers outside of the university, what are the things you want them to be thinking about as it relates to either this project specifically or the research that is to come? What could be their role? Is it to pay attention and watch what comes out? Or what else can we do to engage as community members and Iowans with the research that will hopefully be done?
I don't know if this directly is getting at what you were hoping for, but I do need to point out that a lot of this sits on the cancer registry data that we collect. Our ability to log every single case of cancer in Iowa, understand where they lived, what treatment they got, how long they survive. It is the basis, the fundamental basis for the research that needs to be done. And it is funded in large part by the federal government. Any cuts to the National Cancer Institute often translate to cuts to our ability to capture all of the cancer cases in Iowa. So your advocacy for continued federal funding of cancer surveillance is paramount in being able to do this type of work.
Yeah, I just think about the different domains of like a cancer journey, whether that's through prevention, through screening, through treatment, through survivorship, and even just awareness. I think each one of us plays a role in having that conversation, whether you're a physician, a public health servant, or in a leadership role, or whether you're a legislative body. I think every one of those aspects of a cancer journey, you can play a key role. And, I think all of us are in this room, we know a loved one who's been affected by cancer. We can go back and reflect on that, but certainly recognize those challenges that have come out of that are opportunities for us to engage and think about our everyday lives and where that can happen. And I think each one of us has a role, whatever your occupation is or whatever you serve in your communities. Leverage that role, make that significant, and make people aware of the work you do here, and really how we can be more effective and coordinated to be part of a larger solution.
I would also say, in all my years of working with the consortium and working in cancer prevention and control, I have never seen cancer risk factors pitted against each other until now. I have never seen talking about one cancer risk factor making people so angry and upset because we weren't talking about a different cancer risk factor. I have never seen such thing in my life, and it is at a fever pitch right now. So for what you can do when you talk to your patients or your colleagues or your friends who have cancer, whatever the role is that all of the things are important. The environment and the agricultural exposures are very important, and they're very important for many reasons that transcend cancer. But we know smoking causes cancer. We know drinking causes cancer. We know tanning beds cause cancer. We know so many things that cause cancer, and we have to do things about all of them. We can't push everything aside to focus on one risk factor because we know they all work together. If two people are drinking the same contaminated water, and one person doesn't drink and doesn't smoke and gets lots of sleep and exercise and has a good social support system, they will process that exposure very differently than the person who drinks every day, smokes every day, is not physically active. I don't say this to blame or shame anybody. Many people get cancer who have never drank, who have never smoked. We all know people who smoke their whole lives and never get lung cancer, and the people who never smoke and get lung cancer. That's how complicated it is. And these risk factors work together. If you smoke and your house has a high level of radon, you have an exponentially higher risk of getting it. It's not one thing at a time. And so we cannot, to the detriment of other risk factors that we know cause cancer, only focus on one. So I would ask people to just sort of step back. I know it makes for a complicated message, and that's like the bane and downfall of public health is that everything is so complicated. But it's not just one thing, and we have to work together to mitigate a lot of these risk factors and not just focus on one.
I would urge everyone in this room to pledge that they're going to question what they're hearing, that they're going to actually look for the evidence, look for the science. I think we're in an era where it's very easy for people to say, I think this or I feel this, and I believe, therefore, this is causing this. And we see this happening at all levels. And we can't let that happen here. We need to hold ourselves to a really high standard of what is considered scientifically rigorous. And so I think making sure you hold our feet to the fire for that, making sure that you hold your colleagues, making sure that when you're, this Thanksgiving and sharing turkey with people and people are saying things, is that really true? Where's the evidence for that? I think is really important, because otherwise we're going to be going down paths that aren't meaningful and aren't going to actually save lives.
Hey, I'm a researcher just getting my start at University of Iowa, and I grew up on the west side. I'm from Council Bluffs. My name is Emma, and I was wondering if you guys, I know you get your funding went to the University of Iowa. I was wondering if there were any partnerships with University of Nebraska Med Center or Iowa State or DMAC. I know that $1 million is not a lot, but are you working with anybody else?
So not this time that I'm aware of. I certainly think there's opportunities, again, about having a coordinated message around that. I think one of the reasons I think the University of Iowa was chosen, maybe for the funding piece, was around just the expertise that was in-house for that conversation, and that it was an Iowa entity, being in the state. But that doesn't mean that we can't have those conversations and have a shared message. I'm very close with the state health official over at Nebraska, as well as my partners in Illinois and north and south of us as well. And we know that just like communicable disease, these does not cross, it crosses state lines and it affects all of us, and the same risk factors that they have certainly are risk factors that they're addressing in their states as well. And so I just want to say that there's certainly opportunities for us to engage in a further conversation going forward.
Yeah, and we have a really good relationship with the folks in Omaha, but they are also sitting in a different situation. They're not number 2 in the country for incidence, right? So their motivation looks a little different than ours. We have a little more urgency. So that's also something to consider. I think we all feel very passionate because we're here in the state that this is important to us.
Since we are number 2, is there a way that we can get the insurance companies to do pre-screening if you have, well, I had a friend who just died of stage 4 lung cancer, who smoked for 20 years and no one ever, well, smoked for 40 years, but no one ever screened him for anything, and he just died in June. I have another friend that has cancer, never smoked, and she has stage 4. Also, 2 of them have stage 4. Is there a way we can screen or have the insurance companies screen? How much does screening cost just for lung cancer? I guess.
So I can tell you about one project that's happening at the Holden Comprehensive Cancer Center, and it actually was catalyzed by our colleagues in the School of Pharmacy, and they have a network of community pharmacists across Iowa, many who have trained at the University of Iowa. And they're using that network. They've secured some funding from a partner to have the pharmacist, the local pharmacist that meets their patient each month to pick up prescriptions, to go through those simple screening questions that are easily missed by busy primary care providers or when patients don't come in regularly, and using that as a venue to the screening. The challenge has been the screening involves a low-dose CT scanner, so how do you get that CT scanner? So not every community has one easily accessible. It's hard for many patients to drive an hour to get to one. The way they're addressing that is they're using a brand new type of blood test that has been a major advance over the past few years as an adjunct to the scan, and may in some places be the first step. And second, we're looking into opportunities for a mobile CT scanner that we could bring to rural communities. So those are some of the things we're working on to address that. But I agree, that's very important in a state where there's high lung cancer rates. How do we screen better? And that is a goal in our strategic plan for the Cancer Center.
All right, I have a follow-on question from the young lady, the researcher over there. So the University of Nebraska, the state of Nebraska started funding childhood cancer research in 2014. They were able to get $1 per Nebraskan, so about roughly 1.8 million. And since 2014, they've raised over, I think it's 24.5 million. They started with 10 researchers. Now they're at about 180 researchers on their staff over there. I've spent quite a bit of time talking with Dr. Don Coulter. I don't know if you know Don Coulter, but the things they're doing in Nebraska is incredible. So what we're advocating for in Iowa is $1 per Iowan to go to the University of Iowa for childhood cancer research. Again, we'll do it this session again. What would the University of Iowa do with $3 million for the children?
So I think what we would do is probably work with our pediatric cancer researchers and use that to recruit additional depth focused on the neediest areas. We're already working on recruiting people who we've been working on recruiting someone who's working on neuroblastoma And I think there are opportunities in sarcoma to make some major advances with the expertise at the university already. So we'd like to fill in a few other pieces of research experts who could add to that depth.
I was just going to go back to that screening question because it was a good one. I think in a future state, I've gone to a few health information management conferences, and I keep hearing, data's the new oil. It's just really crude right now. And so part of that is how we use our electronic health records and information and data about us to really identify those that may sit outside of kind of the U.S. Preventive Service Task Force for screening and those routine screenings, and think about people who are higher risk and have that kind of sense of screening for those individuals that are higher risk, and using that data to be more data-driven on an evidence-based approach. So I think there'll be opportunities in the future around that, again, and we'll continue to see some of that. But again, I reiterate, as a primary care doc, everyone continue to check and work with their docs, going to routine physicals, and really looking at these U.S. Preventive Service Task Force recommendations around screening and prevention for cancer.
We are over time, so thank you so very much. You will be hearing more from us. We'd love to hear from you.